Welcome, everyone, to another installment of the Kno2 Partner Engage webinar series, where we bring you industry news, thought leadership, education, examples of the impact of interoperability and connectivity in the market, and new product updates. The Engage webinar series is meant to help partners, current or prospective, understand the power of being Kno2 connected. Together, we are thoughtfully solving healthcare's biggest challenges and empowering the transformation of healthcare at scale. I'm Dr. Peter Schuck, Chief Health Officer at Kno2 and part of the Kno2 Engage webinar team. And with me also is Madeline Crawford, our Senior Manager of Marketing. She'll be talking to you here in just a moment about some of the housekeeping rules and regulations during the webinar. Today, we're going to be talking about connectivity and its role in making virtual care mainstream. More to come. Maddie, you want to talk a little bit about some of the housekeeping concepts?
Yeah, thanks, Dr. Schuck, and thank you all for joining our live webinar today. Before we jump in, I'd like to review a few housekeeping items. We will be recording this session and we'll share the recording in the slides after this call. Make sure to use the chat for any comments as the webinar attendees will be muted. And please don't forget about the Q&A feature at the top of your screen. We will review those questions at the end of the call. But without further ado, let me hand it back over to Kno2's Chief Health Officer, Dr. Peter Schuck, to get us started today.
Thanks so much, Madeline. And I do want to remind you guys of the Q&A one more time. It's really important. I do not like public speaking, and the only thing that helps me overcome my anxiety is to make the audience as uncomfortable as I am here in front of you. And the way I do that is making it interactive. So Q&A is one area, and then we'll have some poll questions as we go through it as well to kind of get you involved and keep you involved throughout today's discussion. And I'm excited about today's discussion. We have a number of folks with us today, and I want to take just a moment and introduce our speakers for today. I'm going to start with Josh Ettwein. Josh is the Vice President of Engineering at Rippl, a digital health company revolutionizing virtual mental health services for seniors with dementia. With over 2 decades of experience in healthcare technology, including leadership roles at ResMed, MatrixCare, and QHIN, Josh brings expertise in building secure, patient-centric systems to his work at Rippl. Welcome, Josh. We also have Travis Rush. Travis Rush is the CEO and co-founder of Reperio Health, a pioneer in at-home comprehensive health screenings that deliver instant results and offer live virtual consultations with licensed medical professionals. With a background in founding successful companies like Sitebox, which was acquired by Johnson & Johnson, Rush brings a wealth of experience and innovation in healthcare to his role at Reperio. And finally, someone who should be familiar to the audience, Ms. Teresa Bell. Teresa Bell is the co-founder, president, and chief technical officer at Kno2, a thought leader and disruptor in health IT for over a decade. Ms. Bell is dedicated to driving connectivity and interoperability in healthcare, simplifying patient information exchange, and democratizing healthcare communication. And I'm Dr. Peter Schuck, as mentioned, the chief health officer at Kno2 and your host for today's webinar. Now, most of you may already know something about Kno2, either from a brief visit at the website, a call with one of our business development members, or maybe you've had the opportunity to hear Teresa or myself speak at one of the many engagements and end user conferences throughout the year. But Teresa, if you don't mind, would you please just kind of give a brief overview of Kno2 for the audience, just to make sure that we're all on the same page?
Yeah, I would be happy to. And thank you for that introduction, Dr. Schuck. I'm excited for the opportunity to speak on virtual care. For me, it's one of my passions and one of the areas of business, I would say, that Kno2 provides, and that we connect with these various virtual healthcare platforms. And we selected 2 today, but we have many partners as part of our ecosystem serving all parts of healthcare. And as I had heard this thing over the weekend, and after I fell off my chair, then I realized the opportunity that we have in front of us, that $4.5 trillion every year of U.S. healthcare is spent on chronic and mental health conditions. So if we look at that kind of staggering number, it's more than our defense budget, by the way. If we look at that staggering number, the opportunity for virtual health to start curbing the tide on that number, there's nowhere else we're going to get that, right? Brick and mortar, with a provider shortage and everything else, we have to turn to groups like Reperio and groups like Rippl and others to help us curb this tide. It's a massive headwind that we're facing into. So excited to be able to be part of that. Just real quickly to touch on what we see here on the screen. Kno2 is the largest communication network in the United States. You'll notice throughout the discussion today that we're not talking about interoperability. Kno2 doesn't see ourselves as an interoperability provider. We see ourselves as a communication network, where behind the scenes, what you see here is sits in the guts, what I call the guts of Kno2, and we're connecting any virtual healthcare platform to the entire ecosystem through one API. So through the single API, you get access to not only national networks, and of course, we're one of the country's QHINs, proudly saying that today, but also all the way through local, state, and local HIEs, everywhere that healthcare information is flowing. Through our single API, our virtual health platforms have access to that, and then they seamlessly integrate it back into their technology stacks, which we'll talk about today at length with Reperio and Rippl. We're honored to be able to support those types of platforms, so they can actually deliver care to the front lines and enable our providers, whatever type of provider may be using the platform, and just as importantly, if not more importantly, enable the patients to access care virtually. And through the Kno2 platform, we're able to do that in real time. So thank you, Dr. Shuck, for that opportunity to introduce Kno2, and I'll hand it back to you.
Well, Teresa, thank you very much for that. And I hear you saying that Kno2 leading what it means to be a QHIN by virtue of its full stack communication infrastructure and its spirit of partnership in helping people solve some of healthcare's biggest problems in their area of healthcare. So wonderful. I'm going to warm up the audience a little bit here I'm going to throw a softball to you. It's our first poll question of the day. It's an easy poll question. And Maddie, if you would make that poll question available to our conference attendees, that would be fantastic. You should see that on your screen now, so take just a minute to respond. And I said it was a softball. It is a softball. This is just testing to see if you have a pulse out there, if you're paying attention at all, and then we'll discuss the significance of the interactions in just a bit. Wonderful, wonderful. So we've got an interesting result, actually, as I'm seeing it. About half of the audience, a little over half of the audience, now getting closer to 2/3, has actually had a virtual care experience in the past, and still about a third, almost to a half, have not had a virtual care experience. So very interesting. Maddie, thank you very much. We'll go ahead and move on to our panel discussion, which is the exciting part of the conversation. So we've got Josh and Travis with us today, and obviously we've had the opportunity to work with them over the last several months to a year, and really have enjoyed getting to know them. But we want to take a minute and have them introduce their companies to you, so you can understand firsthand from them what they're into and how they see virtual care. Josh, I'm going to start with you, if you don't mind. If you could just give a little overview of your company and your company's story and what you guys do in virtual care, and Travis will come to you second.
Sure, thank you. So Rippl, as Dr. Shuck mentioned at the beginning, we're focused on providing highly specialized, 100% virtual mental health care to specifically seniors with dementia. And maybe more so than just the seniors with dementia, we're focused on supporting both the patient and the caregiver. The caregiver is such a huge component of that journey for the patient with dementia. That it's super important to be addressing the needs of both of them. And I would say our care is delivered through, it's a combination of traditional telehealth, if there's anything traditional, I guess, about it, both video and audio, but we do have a lot of patients that, just because of this demographic, they actually do participate in a voice-only capacity. But it's a combination of personalized treatment plans, education for the caregivers on how they can be more effective and take better care of themselves, and then a lot of technology-driven care solutions, specifically around AI and machine learning.
Wonderful, and thank you so much for that. And Travis, I'm going to ask you to give us a brief overview of Reperio as well.
Great, thanks, Dr. Shuck. Yeah, my name is Travis Rush. I'm a CEO and founder here at Reperio. I'm going to actually give a couple of stats that relate to what Teresa said at the very beginning of this, that multi-trillion-dollar number. If you drill that down in the US, when you look at chronic care, it just the individualized level, 60%, the CDC put this out, that 60% of the people walking around in the US have a chronic disease. and they don't know it. And 40% have more than one. And that turns into over $11,000 annually in chronic care management per person that's in those stats. So you see how we could very quickly get to that multi-trillion-dollar number that made Teresa fall off her chair, I think you said. Yeah, so it's a goal of Reperio is to create an annual wellness component that utilizes at-home biometric screenings alongside historical healthcare records, which is where Kno2 comes into play for us, and tying that all together in a very seamless, interactive, at-home virtual care solution that can help with this lack of physician and medical professionals that are going to affect all of us as the population in our country continues to grow and the lack of professionals to help us continues to drop. We have to find another way. And I think part of that way is by putting some of the control in people's hands at their home so they can do some of these things themselves, become aware of some of that risk that may be underlying. So that's our focus right now. And obviously throughout this, we'll talk a little bit more about what we're doing.
Travis, thank you so much for that as well. And I think with that understanding, I think we can get right into the conversation a little bit. I think we're going to jump to a couple other polling questions, but I was reflecting on the fact that I think I didn't do a good job of introducing the topic today, because I assume that we all know what virtual care is. Having been a provider for 20 years in practice, I certainly delivered care in a virtual setting back in the early 2000s, and it was mostly telehealth at that time. But I think just to give a working kind of definition, and Travis and Josh, we've talked about this in the past, virtual care is really a pretty broad spectrum of services, but it's really anything that's not delivered in a brick and mortar setting with a face-to-face interaction in that brick and mortar setting between a caregiver and a individual receiving care or patient. So it could be independent of modality. It could be video. It could be just voice. It could be video and voice together. It could be synchronous or asynchronous, meaning it could be an in-person visit over video or over phone, or it could be asynchronous via text message or app interaction, those kind of things. It can be anywhere from remote patient monitoring, where the person is wearing a device that delivers individual data. That data is aggregated and reported back to the care team, all the way to a primary care visit or a specialist visit over one of those modalities. So there's a broad range kind of in the definition of virtual care. So let's move to our second poll question. And Maddie, if you'll make that available. The second poll question is, as a virtual care platform, how are you currently getting patient information today? Meaning when a patient comes to see you in your virtual world, how are you actually getting patient information today? We'll give you just a minute or two to answer that question. Please select all that apply.
I'm really personally very curious about the outcome of this one.
There's that three-letter word. Fax is probably equivalent to the four-letter words in the rest of the English language in healthcare. It is both loved and hated at the same time, and it is ever present. 67% currently via fax. Matter of fact, I don't know how it can be 67% and nothing else. Now we get some with direct secure messaging. We see some custom integration to different EHRs. That'd be interesting to hear about. I hope that comes up in the Q&A. Maybe I'll bring it up in the Q&A if it doesn't come up organically. Wonderful. And let's go to our last poll question for today. Maddie, if you'll put that one up, that'd be great. How do you share patient records today? So now you've seen a patient or have information on a patient from a virtual visit of some kind. How do you then share that with the appropriate care team that needs to be aware of that information, or the rest of the healthcare ecosystem? And again, select all that apply. Give it just another minute. There are 44 of you on and only 9 responses, so I'll give it just another minute. I'm not trying to call anybody out. I can't see you sleeping at your desk. I can't see you multitasking, but I can assume. Wonderful. A pretty good mix, a little different mix here. A mobile or clinical app. HL7 V2 interface. That would be interesting to understand that one. Again, fax, direct secure messaging. Fax rears its ugly head in everything, doesn't it? For a reason. I mean, it's really simple to understand. It's really simple to understand, and it works. Wonderful. Okay. We'll talk a little bit about those results as we go through the conversation today. But now let's get into the heart of the matter and hear from the panelists. And I'm just going to ask a number of questions. And I'll start with I'll name the person to respond to make it easy for you guys. But let's just go back and forth. I'd love to have dialogue and to listen to you folks talk. One of the things I think that's interesting to me is I did some research in preparation for this, and from my own experience at health systems kind of implementing transformative change in care delivery models, was the rather slow uptake of virtual care. The concept of virtual care has been around for a number of decades. In the 90s, generally around telehealth, specifically trying to scale scarce resources to rural areas that potentially couldn't afford to get specialists in that area. You'd see it in specific specialties where it was easier, mental health and some of those types of things. Then it became the ability to do it by video as people got personal computers. There was a little bit of greater uptake in the 2000s as personal computers came online, and the ability to do video chat and then text chat or text visits, those kind of things. But it wasn't really until the pandemic when the numbers went from about a 1% rather anemic use across the nation in virtual care of all types to a 13 to 17% adoption of virtual care of all types across the country. And again, I mentioned earlier that there were certain pockets in the health system where I was working at the time during the pandemic and leading the ambulatory response to the pandemic. When we shut down provider offices, there was no other mechanism to get an ambulatory visit with a primary care doctor or a specialist other than a virtual care visit. And so we saw numbers skyrocket from 5% pre-pandemic across all services to about 60 to 65% during the height of the pandemic, and then drop back down pretty quickly after the scare of the pandemic was past. Offices were reopened and people went back to their kind of normal modus operandi to the 13% to 15% range. So a significant uptake over pre-pandemic, but not near the level of adoption there that we saw during the pandemic. So I want to ask our panelists, how do you guys see the market for virtual care? It's been something that's shown great promise, and we've talked about it for many, many decades now, 3 or 4 decades now, but it doesn't seem to have reached the point of mainstream healthcare to date. So how do you guys see the market now and in the future for virtual care? And Josh, I'm going to address this one first to you, and then we'll go to Travis.
Sorry, I was on mute. I think in terms of how virtual care has struggled to gain traction, I mean, we maybe are in kind of a unique space in that there's pretty significant technology barriers for a lot of our patients. They, by definition, are considerably older than probably the average, and they also have some component of cognitive decline. They're not comfortable with technology, or they don't have access to it in a lot of cases, and we also serve quite a number of rural and low-income areas, and so that tends to be a technology barrier as well. And then I guess similarly, just from a standpoint of technical difficulties, and like even if the technology is available, poor video quality, bandwidth constrained environments, and literally just user errors can really hinder the effectiveness of our service and frustrate both patients, caregivers, and frankly the providers. I think a lot of it for us is definitely, it falls into that like lack of familiarity and trust and comfort category. I'm interested to hear what.
Yeah, Can I ask a question on it, Josh? Just as because I think you brought up a couple of good points, a number of really good points. Number one is the area that you're specializing in terms of virtual care delivery is largely in older population that may not be as technically savvy and may not have some challenges in that regard. May live in places where bandwidth is not necessarily or Wi-Fi is not prioritized like it is in other areas, because you span both rural and urban areas, I'm certain. Really important points to think about. Travis, how about your thoughts?
Yeah, I think what Josh was saying is super relevant to the uptick in virtual care or lack of, depending on different generations. When you look back on the issue of access to care, so you talked about rural communities where the incentive is a little bit bigger because you have no other option. I grew up in one of those communities where getting in an in-person visit with someone was not very easy, not to mention getting any kind of useful diagnostic data. Blood testing locations or places to do those kinds of screenings aren't accessible in rural communities. So I think in the rural areas of the country, age is less of a factor because they don't have a choice. That's the only way they're going to get care if they need it. But I think in more populous areas of the country where it's more accessible, it's a generational thing. So, and I'll kind of explain why I feel that way. Some of it is the obvious that technology is a hindrance for older people, right? They're not used to it. That's not how they grew up. It's not as intuitive to them, and they have to really think about it, which when your thinking isn't as good as it used to be, it makes it even extra hard to figure out how to use things. And I'm raising my hand saying that I'm seeing that to start to happen with myself when I watch my own kids, where they say, Dad, and they talk to me like I'm losing it. And I'm like, oh no, it's happening. But anyway, so when you go down to that younger generation, I talked to my 20-year-old daughter about a lot of this. And it's very interesting to look at the younger generation and how they look at virtual care as well, duh. Well, is there another way? What do you mean you used to go to a place? Like, that's just beyond their thinking, because the world comes to them in every aspect of their life. Everything comes to them and it happens within 24 hours. So this idea of making an appointment to go to a place that you have to drive to and get time off work and all of that, it's just beyond them. So I think virtual care is going to continue to accelerate as generations continue to get older. But as far as right now goes, I think the pressure that's being put on it is really just a need for access. And like we've been talking about, just some tiny stats on that. I can't remember I think it was the AMA that put out a report that said that between 2010 and 2020, the number of physicians over 60 grew by 48%, and physicians under that age grew only by 16%. So you can see the problem that's coming and has already begun. And, with 100 million people in this country not going to see a doctor already within the last 3 to 5 years, that problem is just going to keep getting worse if we continue to rely on the way it's been done. So I think we have no choice but to adapt virtual care. I think the speed is going to be a little bit related to generational growth. So there's my thoughts on it.
Teresa, I've worked with you long enough. You look like you have something you want to add to that as we go through. Anything to add to that?
Well, I think what was described both by both Rippl and Reperio is all of the headwinds that face into why it's been hard to get virtual care to stay. I think the pandemic based on what you said there, Dr. Shuck, and we saw that it rushed it in as quickly as it rushed it out, right? We didn't see it stick. And that's not only for the headwinds being faced, but that's also for things like reimbursement models and how is it being looked at. But to Travis's point, it absolutely has to take foothold. We have no other choice. He mentioned one provider shortage, but that's true across the board. So with nursing, I'm personally going through an experience with my father right now, and my mother as a caregiver. So what you were saying, Josh, she's a caregiver to my dad who has pretty advanced Parkinson's at this point. That we have no choice but to figure out how to make this fit in. And everything that I was hearing from Josh and Travis was creating an experience that's warm. We have to create the best experience, not only for the patient, but for the provider to get the adoption. And it's got to feel like it's seamless to what they've had before, what they've experienced before, or that it's, to the point on the younger generation, that it's not disruptive to my day. It's got to fit into my day. And that is the point of connectivity. So we actually get it to stick this time, because we didn't take the time during COVID to connect the virtual health platforms. They were just shoved out there. HIPAA was, kind of minimized. Everything was minimized to have it stick. And everybody thought it would stick. I thought it would stick. That didn't happen. And so now we're in the resurgence back, right? And what does it take to do that? So I was just confirming everything we hear has to stick. So how are we going to do that? And what does that mean?
Man, so many good points that we're going to get into in more detail here as we go further through the conversation, because you guys brought up a number of different things. I think one of the things that was important to me too is I don't know, as we've always thought of virtual care in the complete spectrum in which virtual care can be delivered of healthcare services. I think that we have had a niche in our head sometimes of virtual care as either acute self-limited care in replacement of an urgent care visit for a cold or a urinary tract infection, or virtual care is only to monitor ongoing treatment of chronic illness, such as remote patient monitoring for COPD or for diabetes and those kind of things. I think what's so exciting about what we're seeing in virtual care is seeing the far broader application of virtual care from every specialty, every disease state in each care setting. And that really is an expansive thing to understand to me. I think, as usually happens as well, healthcare advances at a faster rate or innovates at a faster rate than the technology to support it sometimes, and also the regulatory environment and the reimbursement models in the past. So one of the things we were talking about that you alluded to, Teresa, in addition to the technical barriers and perhaps generational gaps around use of virtual care, was around the regulatory environment and the reimbursement environment, because that was a big difference that we saw in COVID. And I know you guys experienced that as well. So just your thoughts in that regard. I know that from where I sat in the COVID pandemic, when under the emergency order, the rules around HIPAA compliant video technology were relaxed, when the payers realized that there was no other care being delivered in some settings, and they matched the virtual care rates with in-person rates, it made a huge difference in terms of adoption. And when health systems and other providers realized if they were going to generate revenue and business and care for the patients that they had been caring for previously, they were going to have to find an alternative way to reach those patients. So those things really, in my opinion, drove the adoption of the pandemic. I don't know where you guys sat, but as we've gone kind of relaxed back a little bit out of the emergency order in the pandemic, it's not any wonder to me that in addition to having available in-person visits, virtual care has dropped off. So I'd just love to hear y'all's take on that, thoughts. Is there a different perspective or additional perspective in that? Josh, let's start with you.
Sure. So from a reimbursement model, I guess we were lucky in that. So CMS, I don't know if people are familiar with the GUIDE program. It's relatively new. I think it was officially announced July 31st of 2023. It's essentially a GUIDE is an acronym for Guiding an Improved Dementia Experience. So it's a program put together by CMS to essentially enhance care for individuals living with dementia. It provides a payment model from federal government for improving the quality of life of the patients and the caregivers. There's a big focus on caregivers, but it's person-centered care with regular assessments, personalized care planning, support for caregivers, and for us, it's been a big boon because it's been interesting to see the CMS really view this this disease as something that they've stepped in and they've made an entire reimbursement model around it very specifically. And so that's been great for us. We've jumped all in on it, and we were accepted into the program. We started taking patients under that model in July, and it's been maybe it had a little bit of a rough start in terms of rolling out of the program, but it is really encouraging to see CMS really pushing forward on this.
Yeah, I think it's a testimony too to the biggest individual payer in our country by sheer volume and cash spent. Get behind scaling resources through a virtual care model in terms of the comprehensive care for dementia. Like Rippl, because I think it's incredibly important. The multidisciplinary skill sets to manage a patient and the loved ones with a diagnosis of dementia through the standard kind of 8 years of life expectancy from the diagnosis to the end of life. It is a comprehensive team that requires intensive, frequent touch points that a lot of people don't have access to in person or can't get to in person for different reasons, and having a virtual model to support that is wonderful, absolutely wonderful. Travis, I don't know if you had thoughts in terms of the regulatory or reimbursement environment in its relationship to adoption of virtual care.
Yeah, I do. And I think this is super fascinating conversation because Josh's perspective on this is more of managing existing conditions and trying to get control and comfort and all of that into people's lives, whereas we are more on the tip of the spear, where we're trying to find the problems so that we can hand them off to someone like Rippl or other organizations that do more of the chronic care management. And I think that's obviously one of the things we learned during the pandemic is there's a ton of underlying conditions, as they referred to throughout the whole experience, that people just aren't aware of. And so that's really been a focus of what we're trying to do. And I think, when we talk about the struggles that virtual care has been having, I think a lot of that has to do with the way virtual care has been sort of thrown at us without a lot of time for us to figure out how to do it right. And I think that now this backing up that we're seeing is saying, okay, wait a minute, this is great, but we need to figure out how to make this more efficient, because I think what virtual care has been doing post-pandemic is actually creating additional strain on the industry, because a virtual visit today without any data turns into 2 visits, which is now twice the cost for the carriers, and they don't want that. Obviously, that becomes expensive, and so I think a lot of them are pulling out, saying, "Wait a minute, we're paying for an initial visit, and now we're paying for the next visit because the first visit was just to tell someone they needed to go have another visit after they go get some data to support the visit." So I think that's a big part of Reperio's focus, is to get the data before the first visit. So by sending a biometric solution into people's homes to start the process with data first and then engage in a conversation, you can make that process way more efficient and lower the costs and strain on the system. So I think everybody has to be focusing on that as well.
I love that. I'm going to give Trace a chance to jump in here, but I think that segues nicely into the conversation around connectivity, because when you talk about data, you're talking specifically about 2 things. One is the kit you send into the home to actually get coincident data, blood tests and so forth, that actually can be used in diagnosis and screening. But then there's data that already exists on that individual who might have been seen in the healthcare system somewhere else. And how does a virtual visit become connected to the rest of the healthcare ecosystem such that it's informed on that important data? And Josh, I would imagine this is incredibly important in the chronic disease space like dementia, where it's more than just chronic care management. It is the management of the disease with a multidisciplinary physician-led team. And I think about, Teresa, your comment earlier, and I want you to pick up from here, just this idea that one of the barriers that we didn't really talk about, you alluded to it, for virtual care, in my opinion, was it was always separate from the rest of the healthcare ecosystem. It always had its own system of record, its own platform that it was doing, and it didn't communicate well with the rest of the healthcare ecosystem. So to Travis's point, not only was it double dipping in terms of payment for that, but it was also kind of a double trouble for the patient, right? They had to kind of remember that they were seeing virtually, explain it to the doc. The doc couldn't get the information from the virtual care visit. The virtual care visit couldn't get the information from the doctor. So I'm going to leave it there and segue into, tell us a little bit about your mission, your passion for connecting all corners of the healthcare ecosystem and what that means for virtual care.
Yeah, and I think that was a great lead in, because as I listened to both Josh and Travis describe different, and I loved how you said tip of the spear, Travis, because I think that's absolutely right. And virtual care can sit anywhere. I often reference this example of, and people are probably think I work for them, but I don't, this eating disorder platform that it was so unique and specialized, but it's such a problem in the country. Like 10% of the country deal with an eating disorder, and it wasn't specialized specifically for eating disorders. And nobody, you talk like to a pediatrician, and in my time with Dr. Shuck, he's educated me. And that's kind of an area where PCPs, family docs, pediatricians, they can't spend their time there because they're dealing with such other things. It's kind of scary, right? And so you want to be able to coordinate care. But in the words that I heard Josh, especially you use, but I heard you allude to it, Travis, is this warm experience. And the desire to get through an expedient but warm, informed experience with the patient, whoever that patient is, whether it's over a landline with your audience here, Josh, or it's virtually, it's a actual virtual visit on camera. That experience that me, and that's what I think about when I go to the doc. When I bring my son to the doctor, I want, even though I go only annually right now to the pediatrician, I want that pediatrician to remember my son. And I want them to know as much about my son. And please don't rely on me and what I'm doing every day to remember all this information. Same thing I experienced with my father over the last year, but again, in the last few weeks, is just remember who he is and remembers what's happening, because I'm relying on you to give me the best advice. And that is what we've seen in virtual care is, as Dr. Shuck said, it's been this appendage. And that's why it was ushered in and ushered out as fast as it was. But I wouldn't take back what the pandemic did, because what I think it did is it created the awareness, right? So that awareness was critically necessary. As obtuse as it came in, it was critically necessary to understanding it. And for Kno2 and specifically, it is absolutely core to the mission of this company. I always say bring healthcare connectivity to all four corners of healthcare, no matter what that profile looks like of that healthcare company, of that provider. Make sure that they're connected and that information is easily shared. So doing that virtually, I think that is the magic piece, that we bring these puzzle pieces together, connectivity, sitting on the back end of a virtual care platform to enable that experience for the provider and the patient, to enable access to the data at scale. That is the piece I'll emphasize. If we look at that, those polling questions, every one of those polling questions are point to point. So it's either a point-to-point that I'm having with the patient because they're uploading their information a little bit, or it's a point-to-point custom integration with an EHR. Even FHIR today is still point-to-point, although we're trying to make it something at scale. A virtual care platform can't take foothold until it has connectivity at scale on the back end, because you can't sit there with every new organization that you guys are encountering and say, can we integrate? Can we integrate? Can we integrate? We'll never get off the ground. And that is really the goal of Kno2, is sit on the back end, bring this scale to the solution that Josh, Travis, you guys have. And I think that's where we've seen really this magic come forward, Dr. Shuck, and I'm excited for that.
Yeah, and guys, please jump in. I don't want to dominate the conversation here, but I think building on what you guys have said, I mean, we didn't mention this when we were talking about virtual care adoption, but the idea of convenience, we alluded to it. I mean, the idea that for 20 years I worked in a brick and mortar office and people had to call and ask my front office person for permission to come see me somewhere between the hours of 9 and 5 not during the lunch hour, when it was convenient for me, regardless of if it's convenient for them or not, is almost ludicrous when you think about it. I mean, it is an absurdity. The ability to conveniently reach out and get virtual care services relatively on demand where you are is an incredibly important point, but it works the best if indeed the information you need to make that a useful visit can also be achieved on demand, right? And that's where the idea of connectivity, the query functions and so forth are incredibly important as we go through it. So I don't know, if I'd love to hear Josh and Travis to the, extent you're willing to share and willing to articulate it, where you see this query of information and getting information from the remainder of the healthcare system as important to your kind of portfolio. Travis, I'll start with you on this one, and Josh will come to you.
Yeah, thanks. I think Teresa made a good point that there's two parts to this. One is the perceived value of the visit, that when you walk into a doctor's office and they don't know anything about you, you feel like it's your job now to educate them on you. And that's an impossible task because you only know this much of what the whole picture,
and you don't know what
is about.
You don't know what's relevant to them, right?
Exactly. You don't know what you should be telling them that you're not telling them because you didn't realize that this and this and this turn into this. And so I think that's one piece of it, is making sure there's all of the information in one place. But I think the other thing is speed. My and efficiency in the visit. My chief medical officer here at Reperio, he still also works as a full-time physician, and some of the hospitals that he works at, they require their nurses to see a patient in 7 minutes because they're dealing with overhead and they need to get their billables maxed out to pay for that big building and all the insurance and everything they've got to have to keep those places operational. And you can't have a meaningful conversation with a patient and produce any meaningful results in 7 minutes. That's especially when you don't have all the information in the first place. So it's like a double whammy in the current brick and mortar system and the way that it works. So I think what virtual care and organizations like Kno2 are able to pull together is the ability to get access to historical information in the moment, right before the visit happens, so that when the doctor is walking into that conversation virtually, they're able to have a summarized view of everything that's gone on, every physician they've been to, every medical emergency they've had, whatever medication they're on or they've taken in the past, allergies. That it could pull all of that in one, a few milliseconds, and be able to summarize it and present the nurse practitioner with your entire health history to say, all right, here's where this person's been, here's what their journey has been like, and here's what's going on today. Now that you're starting that off on the right foot better, I think, than even it has ever been able to be. Even in a situation where you walk into a doctor's office and they do know you, they still don't know all the things that happened to you since the last time they saw you, because you probably didn't just go to them during that year or 2 years since you've last visited them. So I think it is what Kno2 is doing, and others in this space. This whole thing won't work without it, because we have to have access to the data. Nothing is of value without data.
Josh, I'd love to hear your thoughts as well.
I would agree 100%. Like especially in our space, we have this sort of like golden hour opportunity when we meet with these patients for the first time, and to sort of reinforce the point about that first visit needs to be incredibly meaningful and useful instead of just being nothing but information gathering. We have very little time from a attention span standpoint, or these patients get irritable very easily if they don't understand what's going on. Getting them to return for multiple visits just to provide essentially basic background information it's absurd. It's not going to work. And so probably is not an overstatement to say we couldn't do what we do right now, at least as effectively as we do, without Kno2. Simply because we are able to, when we get a referral from a PCP, comes directly into us, we can unpack the referral, unpack the CCD. We use a bunch of AI tools that we've written to strip as much information as humanly possible out of the CCD file. So we're sort of preloaded with a lot of information. We can query back onto the network, augment that information even more. So by the time it even gets pushed into our frontline patient engagement folks, they have an enormous amount of data about this patient, and they still have to go through, obviously, and confirm that this information is correct with them. But it's not that constantly like trying to drag information out of people, just to get them through their first call. And then that way, when they are eventually handed off to one of our clinicians, the patient chart is incredibly robust, and it has, everything that they would need to make that first visit incredibly useful, and they're actually being able to provide care rather than just data gathering.
So I'm curious. Sorry, Dr. Shuck.
No, please go ahead.
Josh and Travis, we've talked a lot in this about getting the data, right? Having it come in to be a seamless part of the healthcare delivery system, but also critically important that it's incumbent upon your platforms to share, right? So, because a lot of these patients will still have a PCP, or they'll have a specialist that they're seeing in a brick and mortar, and you need participation. If we take on the spirit of true care coordination, you need participation by the rest. So, how are you guys sharing your data? What does that look like back to the healthcare ecosystem?
Yeah, well, I mean, obviously through a Kno2 platform, it makes it possible for us to now make our data equally available in the reverse, right? As part of the deal with interoperability is it's a two-way street, and you have to agree to share if you're going to take, and that makes sense. That's better for everybody. So that
Travis, what type of information are you guys sharing back to the healthcare ecosystem?
So on our side, it's really not to get into the details of what we do, but I don't know if you're asking me to share a little more information about how this works. So when we're pulling in information, one of the things that we're doing is we're utilizing AI, and I don't want to head us down another road, but to help analyze and ingest the information and summarize it for the nurse practitioner. So we're not allowing AI to talk to the patient, not yet. Right now, we're trying to utilize it as a tool to help the nurse practitioner or medical professional on that end to have a very good understanding of everything, trying to go through health records. If for those of you who have looked at them, no doctor keeps their records the same way. They don't write their notes the same way. Everybody's stuff, they organize it in their own way. The EHRs all work differently. They all, that's a whole different conversation, but it makes it also, I think, equally very difficult for a doctor to truly be able to ingest information from multiple sources on their own, especially when they're, cramped for time. So utilizing AI to take that information in and summarize it and present that medical professional with a summary that they can then dig into if they want to. So we try to bring that in, and then we bring this biometric data in, which is, your cholesterol levels, your glucose, A1C, blood pressure, heart rate, BMI. Those are crucial data points that are the foundation of, cardiovascular disease, which we all know is the leading cause of death in this country. And being able to bring that data in with all that health history and whatever medications they're on, summarize it all together and present that to the medical professional right out of the gate, that sets that visit up for being successful. Then holding on to the transcription that is also summarized about that entire visit and the outcomes and the discharge paperwork and SOAP notes and all of that, and pulling that in and making that now all of it, everything I just mentioned, now available to the next doctor that sees that patient. I mean, now we've got an efficient system.
Yeah. Yeah, I love that. I love the emphasis on bidirectional, which is going to be important to make virtual care mainstream, the bidirectional communication. It's interesting. I was thinking about this old concept about knowledge being power. Knowledge in this case, I have this data. Doctors don't need more data. What we need is information, which is data with context, right? So data that is tied to a patient, a specific part of a patient, that is presented to us in our workflow, in the tools that we use on a regular basis at the time when we need it to make decisions. All of a sudden it becomes knowledge now. So you've made this whole transformation from data through information to knowledge, and knowledge over time becomes wisdom, right? And we actually get better at what we do from a practice perspective. And I think that in this case, the knowledge we're talking about, bidirectional sharing of clinical information at the point of care, actually gives the power to innovate, gives the power to create, to scale scarce resources, gives the power to create a wonderful patient experience and a wonderful provider experience as we go through that. So when I made that statement earlier about solving healthcare's biggest problems together in this process, it wasn't just lip service. It's really, really true. You guys mentioned the provider shortages. We mentioned the poor patient experience, fragmented care. All of those things we're beginning to solve for, the convenience of care, the completeness of care, all of that kind of stuff we're beginning to solve for with this kind of communication connectivity. Yeah, I know we've got about 10 minutes left, or about 8 minutes left, and I cut somebody off and I didn't want to. Travis, was that you?
Well, yeah, it was just that I wanted to pile on to one thing that you said and also reiterate something Josh said that I think is a crucial part of this.
Yeah.
He mentioned the word irritable. And I think that is an overlooked important component on both sides. So if it's not easy, and when we say easy, like everybody, regardless of their knowledge of technology and what kind of mobile device that they have to be able to do it, or it's not going to work. It has to be completely frictionless. Equally, on the backside with the medical professionals, it also has to be easy for them. And I think that's one thing that's been a little bit overlooked.
Very true.
I've never heard a doctor ever say, "I love our EHR system." They don't like the way they work. They always are complaining about it because it's not built for them. It's built by, and no offense, Josh, it's been built by engineers without a UX person in the middle of it, trying to say, look, this is not how doctors operate. You're building this the wrong way. If the doctors knew how to build it themselves, it might be very different. So I think that it's really important. And one of the strategies for us that is key is listening to the nurse practitioners and the doctors to say, look, as we build this virtual world for you, tell us how you want it. How does this work better for you? Instead of fighting with them about whether or not it's going to be as, informative or however they want to phrase their complaints about virtual care. And, I hear it all the time. Well, people need to see a person. Yes, we all agree with that. No one's disputing whether or not you need to see a PCP in person, but there aren't enough of you and it's not happening. So yeah, this is better than nothing. So how about we think about that?
Virtual care is not competition to in-person care. It is part of a complete healthcare ecosystem, period. And this idea, yeah, well, I would even say it's not even supplemental. I would say it's integral. I would say that a healthy healthcare system in the future has to have both parts equally active for the right use cases in the right circumstances. Otherwise, we're not going to be able to scarce resources. We're not going to be able to provide the convenience of care that we need. Provider and patient experience will suffer. So I think they're equal. It's all part of one ecosystem. That's just Peter's opinion, not the opinion of Kno2 or anybody else. But Josh, you look like you're going to say something, and we've got about 5 minutes. Josh, if you'll take us out with your closing comments, I'll open it up to Q&A if there are any burning questions. So please use the Q&A function and put any questions. Right next to the chat button is a Q&A button, and that's where you could put the questions and answers. Josh, please take us out.
I was just going to pile on a little bit to what Travis had mentioned there about it's not about just the patient experience in this situation. It's as much about the provider experience. If you can't get them the information that they need when they need it in a format that they can digest it in, and the experience is horrendous for them, you're not going to retain very many providers on your virtual care platform. And so we've identified that very early on. It was even prior to my time with the company. Of this concept, one of our core values is caregiver obsession. And that is, really trying to make the caregiver's workday experience as pleasant as possible. And I think that's something that's very often overlooked. I mean, I've even worked for a healthcare company in the past that built their own EHR, that their sort of mentality was, it doesn't matter if this EHR kind of stinks because it's our clinicians, their captive audience, which is completely the wrong way to approach it, in my opinion. So yeah, it was. I thought that was an interesting comment that Travis made.
I
would
love
say
that.
There's also an adjacent, so it's not only the provider that's using the technology, but adjacent providers that refer
Yes.
in, right? So they have to have and also need to consume data from your platform, which is maybe was a little bit of a leading question to ask you guys on how you're sharing back. Obviously, as a QHIN, we're very interested in making sure that partners on our network are fulfilling their reciprocity requirements, not just check the box, but doing it in a way that's meaningful to the rest of the healthcare ecosystem. So these adjacent providers also can play. And I know, Dr. Sheck, I think we have a couple questions, so we'll want to get to
and
those.
Just when you say provider too, I want us to be clear that when I'm talking about provider, I'm not limiting it to being an MD or a nurse practitioner. Everybody on the front lines of healthcare has a role to play, and we need to be concerned about their experience. The shortages are not just in primary care doctors, they're all over healthcare because we have not been concerned about the people who've dedicated their lives to deliver care on the front lines in whatever capacity they work. We need to be concerned about their experience. So a couple of things that came in. One was, I won't read the long comment, but one of the attendees was right on about the idea of processing the data and serving it up in a way that's convenient and easy for providers to drive a meaningful visit. We discussed that. I think both Josh and Travis discussed that and how they're using AI to do that, which is a really important thing. The next one was to Josh and Travis. What successful patient engagement tactics have each of you used to keep caregivers and patients regularly engaging with your applications? So Josh, let's start with you, and then we'll go to Travis.
Sure, that's a great question. So we have a very regular cadence of, I mean, I don't know if this is addressing the question exactly as intended or not, but we have a regular cadence of visits with both the patient and the caregiver. And it's really designed around continuing to keep them engaged on a more frequent basis than probably your normal PCP visit would be. Under the guide model, we're actually required to hold these visits on a very particular cadence, and they specify like which practitioners need to be handling which portions of the care model. I think for us, the goal is really around keeping the patient experience very, like I think someone else mentioned on the call today, warm. When I hear sort of success stories internally that are presented at town hall meetings and things like that about a particular visit or group of visits that went particularly well with a patient and one of our clinicians, they're always very much around it being patient-centered, making the patient feel heard, understanding their problems and providing them with like real actionable solutions for the things that they can do to make theirs and the patient's life better. I don't know if that's exactly the answer you're looking for, but that's, yeah, I would say it's very patient. It's very dyad centric, the dyad of the patient and the caregiver in our case.
And you guys are probably in your model touching patients pretty frequently, reaching out to patients very frequently by nature of the model as well. So those frequent touch points are probably very helpful in engaging folks. Travis, how about you?
Yeah, and I know we're running up on the end here. I think we're a little bit different because we're not designed to be a chronic care management solution. That's not our goal. We're more of a referral resource. We are out there looking for patients and identifying risks and potential problems that we then can refer to people like Rippl and others to say, hey, we're going to refer you to this organization who specializes in this. And so that I think that's also a needed component of this entire process. Again, can't rely on people to diagnose themselves and figure out where they need to go next. You need the medical professionals to identify the issue and then say, all right, based on what I know and where you've been, here's where I think you should go next. And that's I think where we're trying to focus.
Wonderful, guys. And with that, we're at time. I would be remiss if I didn't say, I hope that if we've done our job well, we've at least interested you in the importance of connectivity and the relevance of connectivity to virtual care platforms. Please, if you want more information, reach out to us either by our website at Kno2.com, or you can reach out to Teresa or myself directly here. We'll be happy to answer your questions. I want to thank our guests, Josh and Travis. Really appreciate not only you being here today, but the broader partnership. And we've learned so much in working with you guys and getting you guys connected that it's been a real pleasure. And it's nice for us to see connectivity in action because we really believe it's the impact of that connectivity that is the most important thing that we can bring to healthcare. So with that, if you want to stay up to date on all things Kno2 or all things connectivity and healthcare communication, you can follow us on our podcast at Notify. You can find it on all of your podcast platforms. Travis has been a guest on one of the episodes. I'm certain that we will have Josh on one of the episodes before long as well. So more to come on that as well. We're about to launch season 2 coming up mid-September. Once again, thank you all for joining. We look forward to seeing you next month on our next Kno2 Engage webinar series. Thank you.
Thank you.
Bye-bye.